Alright, welcome to the lecture for Module 1 for Medical Ethics Online. I'm your instructor, Eli Weber. Before I start with the content for this lecture, I want to say just a little bit about what these lectures are for and what their purpose is and how you should incorporate them into your class preparation. The idea behind these is that I'm not going to summarize the reading. I'm going to just assume that you've done the reading, and I'm going to try to highlight some key points of the reading and maybe develop some of the ideas from the reading a bit further. So it's ideal if you've done the reading before you view the lecture. However, it's not required. Whatever works better for you is what you should do. Now with that said, let's go ahead and move into the content of today's lecture. And if you have any questions about sort of how to approach the lectures for the course, feel free to email me and let me know. But what we're going to talk about today is just this idea of what medical ethics actually is and how we should approach it. I think we all have kind of an intuitive idea of what ethics and morality, at least, is all about. But when it comes to the formal process of doing medical ethics, we want to be able to do a bit more than just... We want to go beyond just sort of the casual conversations that we're able to have with sort of friends and family members. We want to do this in a systematic way so that it's efficient and productive, so that we make progress on answering ethical questions in medical contexts. So that's what we're going to try to figure out, is how exactly to do that. And the goals of this lecture, one goal is going to be to explain the distinction between medical ethics and bioethics. That's something that you should have noticed in your reading, that there is a little bit of ambiguity there. Two of the articles do a nice job of actually distinguishing between the two, but often, especially just say browsing textbooks on Amazon, you'll get medical ethics and bioethics texts somewhat interchangeably, but these are not exactly the same discipline. So we want to talk about what the distinction is there, because it's somewhat important, and it's going to be important for understanding the methodology that we're going to employ in this class. The other thing that we're going to do is I'm going to briefly articulate what I take to be the central conflict in medical ethics at the moment, and that's this conflict between autonomy and paternalism. Unless you've had some ethics, you're not going to understand what those terms mean, so I'll briefly explain what those terms are all about, what those concepts involve, and then talk about some ways in which conflicts and ethical problems in medical ethics can be understood as really just conflicts between autonomy and paternalism. Then I'm going to discuss the role of principles, theory, and argumentation in medical ethics, because these are basically the tools of the theoretical philosopher and the applied philosopher. So we want to know how we should think about ethical principles, theory, and argumentation in approaching questions in medical ethics. Alright, so let's start with this distinction between medical ethics and bioethics. Now, medical ethics has one of its distinguishing features is that it relies on a professional ethic of medicine. Usually this professional ethic is going to be provided either by some governing professional organization like the American Medical Association, or it might be embodied by certain oaths that are sworn, like the Hippocratic Oath. But it's also going to come from both legal codes of conduct for medical practitioners and social expectations, social norms associated with being a doctor. Now the idea here is pretty simple, but also pretty important, so make sure that you understand this clearly. The idea here is that there is a set of moral rules. There's a way that doctors are supposed to conduct themselves in virtue of their status as doctors, in virtue of being in that professional field. And we try to impose this by way of both professional ethical codes and social and legal codes. This is all sort of externally imposed. And the nice thing about this feature is that when a medical practitioner, a doctor, a nurse, a medical researcher, are trying to make ethical decisions, one thing that they can look to is what their own professional code of ethics, another way that doctors will refer to this, and nurses, is this notion of standard of care. You may have heard this phrase before. It's this idea that there is a standard, there is a norm, and it's a professional norm associated with a certain situation. So this can be a helpful tool for a medical practitioner. Now the idea here is that as a medical professional, you have certain obligations that follow from your role. So, in virtue of your status as a doctor, in virtue of you filling that social role, there are certain things that you're obligated to do, like act for the sake of your patient's well-being, for example. Or another way of thinking about this is in terms of an activity-based obligation. So, in virtue of engaging in the practice of medicine, not necessarily occupying the role of doctor, because there are sometimes people that engage in that practice, even though they don't occupy that role. In virtue of that activity, you have certain obligations. So if you're going to engage with someone, interact with someone in this particular way, there are certain obligations that follow from that. And we'll contrast. There's a big difference between that understanding of where obligations come from and the bioethics understanding of where obligations come from. And another important feature of medical ethics is just that it's a teleological approach to ethics. The idea here is that there's a purpose behind medicine. There's something that medicine is for. There's something that we're ultimately trying to do when we're doing medicine, and that purpose can inform our conduct. It can tell us how we ought to be acting. Now, bioethics, as you may have noticed from the Singer reading, arose in the mid to late 60s, early 70s, and then has continued to develop into the present day as a kind of critical challenge to professional ethics, and especially the professional ethics of medicine and research. Now, as I said, that an advantage of having a professional ethic to appeal to is that you have a standard that can guide your conduct, get you through some potentially hairy situations. You can look to this standard and you can feel confident that there is a general endorsement of this standard. I mean, if you act in accordance with the AMA's Code of Conduct, that is going to give you some justification. It's going to give you some reasons in support of your decision if it were to be, say, challenged by either legally or maybe by other members of your profession. You know, it seems like a good reason, or you might think that it's a good reason for doing something if it's consistent with the code of conduct for your profession. Bioethics takes a different view. Bioethicists say, look, we've got this code of conduct, this professional ethic of medicine and research, and that's all well and good so long as what those codes say is the right stuff. And historically, the Baker piece is especially helpful in drawing this out. Historically, that code of conduct hasn't always said what we think it should say. In particular, the notion of patient rights was suspiciously absent from professional codes of conduct in medicine. And one of the consequences of the rise of bioethics in the late 60s and early to mid 70s was this inclusion of this notion of patient autonomy and patient rights. That wasn't really there before. So bioethics takes something of a critical stance towards these professional standards that otherwise guide medical ethics. How does bioethics do that? Well, it applies ethical generalities to medical practice. I mean, there are certain ethical rules that we think cross-apply to different kinds of cases. We think, or tend to think, that if you're doing, medical research, medical practice, but also just in your everyday interactions with other people, that there's a certain standard for how you treat them. You should treat them like a person. You should treat them like an autonomous agent, as a choice maker, as a legitimate choice maker. You shouldn't harm them deliberately for your own gain or amusement. And there are just certain basic, and those are really general and fairly uncontroversial. But the idea here is just that there are ethical generalities that aren't unique or specific to medical practice, but that ought to inform the ethics of that medical practice. So if it's generally bad to do something that isn't in someone's best interest to them, then it's probably bad to do that within the field of medicine as well, or at least that's the general idea in applying ethical generalities to a specific field like medicine. A key feature of bioethics that again distinguishes it from medical ethics is this idea that obligations follow from the rights that patients or research subjects have in virtue of their status as morally significant beings, in virtue of their status as persons. So it's not in virtue of my being a doctor that I ought to treat my patient in a particular way. It's in virtue of the rights that they have as a human being, as a person, as a moral person. I shouldn't say human being, because animals probably have some, almost certainly have some significant moral status. We don't think it's okay to just sort of tear animals to pieces for the sake of research. So that's a misspeaking on my part. But the general idea here is just that, in contrast to medical ethics, it's not the role of a physician or the activity of medicine that creates obligations. It's the rights that patients have as moral persons. And finally, bioethics tends to be more deontological. This is sort of a continuation of the previous point. It's just this idea that rights of individuals are what's really important in thinking about problems in medical ethics. We need to think about what patients have a right to, what patients don't have a right to, and also what physicians have a right to and what physicians don't have a right to. That's something that's sort of obscured frequently. What do physicians have a right to do and not do, agree to and not agree to? And notice that that's substantially different from this teleological view that we see in medical ethics, where the purpose of the activity guides the ethical thinking, as opposed to the rights of the involved individuals guiding the thinking about ethics. Okay, now we need to talk a little bit about this, as I said, what I take to be the central conflict in medical ethics, and that's this conflict between autonomy and paternalism. Now, the first thing we need to do is distinguish what these concepts are all about, because otherwise this isn't going to mean anything to you. So autonomy, probably a concept you've heard before, is this idea that agents, so humans most often, have a right to be self-determining. This is just the idea that individuals have a right to live the life that they want to live, the life of their own choosing or of their own making. This is the idea that you are and should be like the author of your own life. If your life was a story, you would be its author. Autonomy says, look, that's appropriate. You have a right to this. When people interfere with this, they are doing you wrong. They are perhaps harming you in some relevant way. And for most people, autonomy is supposed to be a kind of core component of a good life. We tend to think that if you don't have autonomy, or if you are prevented from acting autonomously, even though you are an autonomous being, so even though you're capable of making decisions for yourself, we prevent you from doing that, that's bad for you, that it makes your life worse. So we tend to think autonomy is pretty important. And if you'll notice, socially we think that as well. We tend to think that violations of rights are really serious. We tend to be a rights talk kind of society. We tend to talk about rights and freedoms quite a bit. And the theoretical concept behind this is just this notion of autonomy as a core value, that this right to self-determination is of supreme importance. Now, paternalism is the idea that it's sometimes legitimate to restrict autonomy for an agent's own good. So sometimes I can actually interfere with your autonomy, and the reason that's okay is because it's good for you that I do that. Now, the classic example of this is seatbelt laws. Most people think that seatbelt laws are a kind of paternalism. The idea there is, look, even though maybe you're competent to decide whether or not you want to wear a seatbelt, we use the law to encourage you to do that. Because we think it would be good for you, right? We think that it's better for you to wear your seatbelt, even if your own free choice would be not to do that. Now, that's a problem if you think that autonomy is really, really important. So we need some reason, other than just it would be good for you, why it's okay to interfere with autonomy. Now, there are two ways that people might give reasons for or justify. Philosophers talk about justifying positions quite a bit. For those of you who haven't had any philosophy or any ethics, it's probably important that I say that. We need a reason. We need something that justifies this restriction upon autonomy. We have to say more than just, it's for your own good. Because lots of stuff is for your own good, but we don't think that it would be legitimate to impose it upon you. It's probably for your own good that you eat more vegetables than you do, but we don't think it would be all right for me to come to your house and force them down your throat, for example. So, two ways that this can be justified. One is what's called soft paternalism. And this is the idea, the soft paternalist says, look, it's okay for me to restrict your autonomy, to interfere with your choices for your own good because you're incompetent in some way. So when we interfere with the choices of people that are mentally ill for their own good, we sort of institutionalize them and make them take medication that they sometimes don't want to take. The justification is, look, your mental illness makes you incompetent to make good choices for yourself. So we interfere with your choices for your own good. And it's legitimate in virtue of your incompetence. Now contrast that with hard paternalism, where we say, look, whether it's not that you're incompetent, or maybe you are, but that's not our reason. Our reason is that the stuff that you care about is the wrong stuff. So when you think that it's of greater value to choose not to wear your seatbelt than to be safe by wearing it, you just care about the wrong thing. You care about sort of freedom of movement in your car, I suppose. And what you really should care about is your long-term safety. And so if you don't want to wear a seatbelt, the hard paternalist would say, it's legitimate for me to go ahead and make you wear your seatbelt because it's for your own good, and you just have the wrong values. Now, there are soft paternalist explanations of seatbelt laws too. Some people think, well, look, it's legitimate because seatbelt laws are legitimate cases of paternalism because we tend to think that people aren't very good at understanding statistics and the biology behind head trauma. And if people really understood, at least the people that don't think they should have to wear a seatbelt, if they really understood all that data and all that information, they would choose to wear the seatbelt. So they are in some sense incompetent. So we can interfere on their own behalf. Now the hard paternalism says, I don't care if it's not that you're incompetent. It's that you care about the wrong things. You have the wrong values. We'll talk about this distinction more as we move through the course, but the point here is just that we tend to think that soft paternalism is acceptable, right? We think that it's okay to interfere with the choices of severely mentally ill people in order to protect them. We think that we're protecting them from their own bad choices. And what we're doing is interfering with their non-evaluative components of their life. We're interfering with them in virtue of lack of information or lack of psychological competence. We're not interfering with their values. And for whatever reason, we tend to think that that's okay, but interfering with people for the sake of their less than ideal values is not okay. It would be wrong. There would be something morally problematic about telling people, look, when you care more about not wearing the seatbelt than about being safe, you care about the wrong stuff. But it seems perfectly legitimate, we think, or socially we tend to think this, to say, look, if you really understood all the facts, you would decide differently. Anyway, I don't want to belabor the point about paternalism more than I already have. If you have further questions about that, because it is complicated, feel free to email me or post something on the discussion board and we can clarify that further. Okay, how does this conflict come up in medical ethics? Because at this point it's probably not clear how these concepts can conflict. So one, suppose a patient wants to participate in an experimental drug trial. So this is going to be a trial of a drug that has not yet been approved for general prescription. But they're terminally ill. It's created this attitude of desperation. They're willing to agree to almost anything that might help them. So they're willing to agree, for example, to a phase 1 clinical trial, which is a toxicity test. It is not a test of efficacy. All that a phase 1 trial tests is whether or how much of a drug will make someone sick, and sick in what way. There are patients that are sufficiently terminally ill, and you can find websites where they sort of congregate and talk about this issue. It's especially common among cancer patients, terminal cancer patients. Some of those patients think they should be allowed to freely participate in experimental drug trials and use experimental drugs. There is a big question of whether or not the desperation, the psychological desperation associated with terminal illness makes them competent or not. Now, you might think, well, you might think that terminal illness automatically disqualifies them. So we should forbid this kind of participation in experimental drug trials for soft paternalistic reasons, because the individual is not competent. So we can interfere with that free choice to participate in this drug trial because their desperation makes them incompetent in some way. Or you might think that no. So long as they understand what they're getting into, autonomy is so important that we should let them participate. So that's one example where these values can come into conflict. Let's take another case. Suppose a patient, we know this to be true, that a patient is more likely to be responsive to a treatment regimen if they have a positive attitude about their prognosis. So patients do better when they think that they're going to get better. Basically, the more psychologically positive they are about a treatment, the better the results tend to be of that treatment. Now, suppose you're the physician handling this particular patient's case, and you happen to know that the prognosis for this particular patient with regard to a certain treatment is very poor. Their chances just aren't good, say 20% chance of survival or something. If the patient asks you what their prognosis is prior to starting the treatment, you have two choices. You can tell them the truth, you have about a 20% chance, and actually make it less likely that they'll recover, or you can lie to them, or more commonly, or kind of middle ground would be to be kind of evasive, be vague about the prognosis. Deliberately avoid answering the question. Now, we tend to think that when you withhold information from people or when you lie to them, that you're in a sense violating their autonomy, because you're preventing them from making fully free choices, right? They're making choices without all the relevant information. So that's a sense in which you're not treating them like autonomous, good choice-making agents. There's an argument here that in virtue of these sort of potentially good consequences, because it would be good for them, it's legitimate for us to violate their autonomy and not tell them the truth. On the other hand, you might think that autonomy is so important that it requires that we tell the truth. That's another way that there might be a conflict. A third possible conflict, suppose a couple is undergoing in vitro fertilization, and they, as part of the process of embryo selection, they opt not to use any genetic testing in selecting which embryo they want to have implanted. And suppose that the couple has a history of Tay-Sachs disease in their family. Tay-Sachs is an extremely serious condition. Google it. It's quite horrifying. Prognosis is virtually terminal 100% of the time. There's no cure. There's really no effective treatment. It's degenerative. It's progressive. It typically kills those who have it fairly early in life, although there are cases of adult-onset Tay-Sachs. Now, the point here is that the couple has the option, through genetic testing, of implanting an embryo that is neither a carrier of the gene nor has the disease themselves. So we can have a Tay-Sachs gene-free embryo if we use genetic testing. So you might think that it's best for the couple. What would be good for them would be to use genetic testing. Now, the couple, for whatever reason, and there are lots of reasons people could give, they opt not to use genetic testing. If we think autonomy is important, then we should probably respect that choice, provided their reasons aren't sort of insane or ridiculous or improperly informed or something like that. On the other hand, we might think that the outcome is sufficiently important, that we get a child that doesn't have Tay-Sachs, that it would be legitimate to interfere with that autonomy. And again, we're not trying to resolve these cases. We're just looking at possible ways in which this conflict can arise in medical ethics. And there's one more case that I was going to discuss, but for the sake of time, I'm going to skip. Just pause the slideshow and the audio if you want to read it over and think about it. Okay, let's move to the third part of the lecture here, which is discussion of the methodology of medical ethics. This is going to be drawing mostly from the Vaughan reading. Now, in the Vaughan reading, he talked quite a bit about both ethical theory and ethical principles. I'm going to spend quite a bit of time on ethical principles. I'm not going to talk much about theory, mostly because in contemporary medical ethics, theory tends to be sort of in the background. So people will talk about certain principles like autonomy being justified or being legitimate in virtue of some ethical theory. But most of the principles that we tend to think are important in medical ethics can be justified on any of these ethical theories. And what tends to happen is that contemporary bioethicists and medical ethicists tend to sort of pick and choose in a way that's not entirely legitimate philosophically. They pick and choose sort of what principles to appeal to. But the point here is just for you to understand the way in which principles and theory are part of the process. So we've already talked about this, about one of the principles that is dominant in medical ethics, and that's this principle of autonomy, this idea that patients, barring circumstances that make us think otherwise, patients have a right to choose. Experimental subjects have a right to choose what kind of treatment they want, what sort of experimentation they're willing to participate in, how they want their life to go. Another principle is the principle of beneficence, and this has two features to it. One is this notion of benevolence, the idea that we should try to promote people's interests, do what's best for them, advance their interests or their good in some way, and as well as this notion of non-maleficence, the idea that we should at least not harm people. And in medical ethics and just in ethical and moral thinking in general, we tend to think that at a minimum we should do no harm, and at the maximum we should also try to promote interests positively. If we can do both, that is preferable, but we should really at least try to do no harm. And some people split these up into separate principles, but for the sake of your reading, this is all described as a principle of beneficence. In the course, in what follows, if you want to talk about benevolence and non-maleficence separately, that's totally fine. It's up to you. A third principle is the principle of utility, which is the idea that when we're making a decision about some ethically significant situation, what we should do is look at all the positive features and all the negative consequences, and we should do a kind of moral arithmetic. We should find the sum, and we should do the thing that has the best positive consequences over and against the negative consequences. So if some action brings about more good than bad, so it has some negative consequences, maybe we violate patient autonomy, but we bring about a fully developed child that does not have Tay-Sachs disease, you might think that the positive benefits of having a child that doesn't have Tay-Sachs disease outweighs the negative of violating parental autonomy, as in the case that I discussed in the previous slide. That's one way you might use the principle of utility. Notice that just appealing to utility, there's still some moral work to be done because we have to decide what outweighs what. You might think that autonomy is way more important than having a child that doesn't have Tay-Sachs disease, because as we'll get into in the course, and you may already know from just sort of basic genetics, even if both parents are carriers of the gene, there's only a 25% chance of Tay-Sachs. So you have to weigh that 25% chance of Tay-Sachs disease in a case like that against the value that we ascribe to autonomy. So there's still a lot of work to be done if we think about things in terms of utility. And finally, there's a principle of justice, and this is just the idea, and mostly this in medical ethics has to do with distribution. We tend to think that fairness is really important, both in our lives and in medical practice and in medical research. We tend to think that it shouldn't be the case that one social group gets all the benefit without also taking on some of the risks. We don't think it would be okay if only extremely poor people donated their organs, but mostly extremely wealthy people received those organs. We think that there's an injustice taking place there. When you hear people talk about things like a right to health care or equal access to health care, that's based on considerations of justice. The idea that we all ought to be, and the basic idea behind justice really is just that we should all be treated fairly, not differently in virtue of arbitrary features like our race, our gender, our social class, our economic status, our gay and lesbian status, anything like that. And as I mentioned, most of these principles can be legitimized according to an ethical theory. Now, what ethical theories typically do is provide a framework for ethical decision making. So utilitarianism is the most obvious example, and we've already talked about the principle of utility. Utilitarianism is just the application of that principle, this notion of weighing costs and benefits, for lack of a better word, don't think of that just in financial terms, because there are all sorts of moral and non-economic costs and benefits to moral decisions. But this general strategy of weighing costs and benefits, we might think that that's how moral decision making should be done. We should think about what good would come from a choice, but also what bad would come from a choice, and we should do the thing where the good outweighs the bad. Fairly intuitive. And we might have certain principles. We might think that autonomy is a good thing, even though we're utilitarians, because in general, autonomy tends to bring about, respect for autonomy tends to bring out really good consequences. And there are other ethical theories as well. Virtue ethics, the role-based approach to medical ethics tends to be grounded in virtue ethics. Virtue ethics is just the idea that there's such a thing as being a good person. There's a right way for a person to live and act and conduct themselves. And if we know what that is, that standard will inform how we interact with other people. And then deontology and finally contractarianism are just two other ethical theories that I'm actually not even going to talk about, because the point here isn't so much for you to get a bunch of ethical theory, it's for you to see the way in which ethicists rely on theory to legitimize and justify moral decision making. So one practice that's really common in ethics, or at least has been in the past, is that if we want to figure out what we should do in an applied ethical situation, we should start with the correct ethical theory, see what that theory says we ought to do, and away we go. Simple, right? Well, not so much. There's a lot of disagreement about which ethical theory is the correct one. Not everyone agrees about what the assessment is, given some ethical theory. And so what a lot of contemporary bioethicists have done is they've moved to this principled approach, where they justify certain choices based on the relevance and significance of different principles. So you might say, look, in the in vitro fertilization case that we talked about, what we ought to do is respect the parents' choices, because autonomy is so important that actions that violate autonomy ought to be avoided. When we don't respect the parent's choice not to employ genetic testing in selecting an embryo, we violate their autonomy. That's bad. So we should respect their autonomy and not use genetic testing. And depending on the principles you appeal to, you're going to get a different outcome. But the point here is just that you should ground your reasons in some theoretical and principled considerations. We need some basis for thinking that your conclusion in a particular case is correct, and theories and principles allow for that. Now, one thing that the Vaughan book makes quite a big deal about, and that we're going to talk about a little bit more, especially at the first part of the semester here, is this notion of argumentation. Now, an argument is not, as the text mentions, just a bickering session, right? It's not what we do with people when they use all the toothpaste and we're mad at them and we argue about whose turn it is to go buy more toothpaste. An argument is a formal, structured set of sentences that are related to each other in such a way that they prove something. So arguments are sentences that have certain logical relationships, and in virtue of those logical relationships, they count as evidence for a certain point of view. The bottom of this slide is a good example, although this is not a good argument. So, suppose if Carl is a person, Carl is a desk lamp. So in virtue of his personhood, he is also a desk lamp. And it turns out Carl really is a person, so from that we should conclude that Carl is a desk lamp. This is what's called a valid argument. What that means is that if these premises were true, the conclusion would have to be true. So if it were true that if Carl is a person, then he is a desk lamp, and Carl is a person, the conclusion would have to be that he's also a desk lamp. Now that's ridiculous. But the reason that this is still considered a valid argument is that validity is not concerned with the truth of premises. Validity is only concerned with the way that premises are related logically. Now, there are formal procedures for evaluating this, but what I want you to notice is just that validity has to do with logical relationships between premises and is distinct from whether those premises are true. So when someone says that argument is valid, they don't mean though that argument is a good argument. They mean that it has the right kind of logical relationship. Soundness is the other way that we think about arguments. Now, soundness includes validity. So when I say an argument is sound, what I'm saying is that it's valid and the premises are true. So the previous argument is valid, but the first premise, if Carl is a person, then Carl is a desk lamp, obviously false. There's no reason to think that just in virtue of being a person, you are also a desk lamp. In fact, we think that there are no cases where being a person coincides with being a desk lamp. So that previous argument, though valid, is not sound. Now, the reason that I make this distinction here is because a lot of people will talk about things like valid premises or valid points. For the purpose of philosophy, when you talk about validity, you're talking about arguments. So only arguments can be valid when you're doing philosophy. Points of view aren't valid. You should say something like, that point of view is legitimate, or it's well-founded, or something like that. You shouldn't say that it's valid. Valid has to do with logical relationships between premises. And the other reason we're talking about this is that when you're evaluating an argument, probably the easiest thing to do is decide whether the premises, the supporting evidence, involves sentences that are true. So for that previous argument, that first premise, that first supporting evidential sentence, is clearly not true. So at that point, we don't even care if the argument is valid, because we know that some of the evidence is false. We're done. We know that that's a bad argument. Okay, I want to conclude by talking about just two considerations that people tend to place too much weight on in ethics courses, and I want to talk about why I think these considerations are given more weight than they should. And this would be a good topic for discussion, so if anyone wants to raise this issue on the discussion board, just post a thread, ask your question, and we can talk about it. One of these is relativism. Now, there are two types of relativism. First, there's individual relativism, which is roughly the view that whether some action is right or wrong depends on whether I think that it's wrong. So when I say murder is morally bad, I'm just stating sort of my own personal opinion about that. And that sentence is true just in case I believe it. So if I think that murder really is morally wrong, then that makes murder morally wrong. In contrast, when you say murder is morally acceptable, that's also true, because all you're doing is reporting your own opinions and views. People tend to find this really attractive for some reason, because we tend to live in a world where we want to be, it's a multicultural world, where we care about diversity, and we think that respecting other people's viewpoints is really important. And all that stuff is really important. But it doesn't follow from the importance of diversity and the importance of respecting other people's opinions that those opinions are always true just because people have them. And I'll talk about that more in the cultural context. But with regard to individuals, the biggest problem with a relativistic point of view is that it makes moral disagreement impossible. So in this example where I say murder is morally wrong and you say no, it's morally permissible, we're not having a real disagreement, because you're just stating your opinion on the wrongness of murder, and that's all I'm doing too. So this is comparable to a disagreement about whether we like spaghetti. If I say I like spaghetti and you say I don't like spaghetti, that's not a real disagreement. We're just stating our different preferences. And individual relativism says that's what morality is like too. And we tend to think that that's not true. And so, I mean, perhaps you disagree. If so, shoot me an email, start a discussion, let's talk about it. But my suspicion is that you don't actually think that. You think that it's possible for people to be wrong. We don't think that when pedophiles think it's okay to look at child pornography, we don't think that they're correct about that. We think they're making a mistake morally. We think they're getting something wrong. And to take the similar case of cultural relativism, we think that cultures that think it's okay to do things like exterminate Jews or engage in female circumcision and even force female circumcision upon young women, we tend to think that those cultures are making a moral error. Now, the cultural relativist says, look, whether some action is right or wrong just depends on whether a relevant group of people thinks that it's wrong. So one concern with cultural relativism, now people tend to find this view more attractive than individual relativism, but a problem is that we intuitively think that some cultures are wrong. We think that they're making mistakes in their moral judgments. And there may be good explanations for those mistakes. You might think that the cultures where female circumcision is considered acceptable, that they have incorrect views about biology or about sexual practices. They perhaps have unjust sexual norms or gender norms. I mean, there are all sorts of explanations of this. But we tend to think that there is something morally objectionable about this. Now, you can always, quote, bite the bullet and say, no, in fact, that's okay. You know, it's what's right and wrong is just whatever a group thinks is right or wrong. But if you're going to take that view, you have to be fairly tolerant of some pretty morally dubious stuff. So that's one major concern. And the other major concern with relativism in general that applies to both individual and cultural relativism is just that simply because a group engages in a practice, that is not or an individual thinks a practice is acceptable, why should we think that's a reason to think that it's correct? Why does the fact of a group doing something count as a reason that it's the right thing to do? We might think there's a big difference between what people or groups do and what they ought to do. Okay, so relativism is one consideration that we want to be sort of watchful of. We don't want to be sort of overly reliant on appeals to relativism, because people tend to try to avoid ethically sensitive topics by just saying things like, oh, well, you know, who's to say what's right or wrong? Well, what's good for you is, you know, that's what's important. What's good is what's good for you. But when we get to the really important, controversial ethical questions, we tend to back away from that. We tend to think that, well, what's good for you is whatever you think it is, but if you're a pedophile, you're making a mistake. Or what's good for you is good for you, is just whatever's good for your social group. But if you're forcing women to cut off substantial portions of their genitalia, you're making a mistake. You're getting it wrong. And I think that when we're really honest with ourselves, we actually agree with the rejection of relativistic points of view. So be careful about being overly reliant on these kinds of relativistic appeals. Now, if you really think relativism's right or true, that's fine. I'm not trying to suggest that this is a point of view that you can't defend. Just don't default to it. Don't avoid real contemplation and real thinking about these issues by just defaulting to this sort of yay diversity view where you don't think critically about what that view implies. Okay, the other consideration is religion and ethics. Lots of people maintain, and it's been maintained for a long time, although less so recently, that questions about right and wrong are really just questions about what a religious faith says. So when we're trying to figure out whether abortion is morally acceptable or not, we just have to look to the tenets of our faith, whatever those tenets may be and whatever that faith may be. And rather than discuss sort of problems or concerns with this kind of thinking about ethics, I want to just note a couple of problems that relate specifically to medical ethics. Medical ethics is a practical discipline, right? The idea here is that we're making decisions that really affect real people. Hopefully, and my goal for this course is to make you better equipped to deal with the kinds of situations that you're going to face in your actual job, whether that's as a medical service provider or a medical administrator or a researcher, or something that's maybe not as directly related to the discussion so far. But hopefully we'll find something that makes this relevant for you. If nothing else, you're probably all going to be patients. Medical patients at some point in your life. So you should care a little bit about medical ethics, if only for that reason. But the strict appeal to religion is problematic in medical ethics for two reasons. First of all, is the problem of religious diversity. Because medical ethics is an applied practical discipline, we need rules that apply across religious beliefs. That includes people of no faith. If you attempt to justify some moral medical decision, some medical decision with ethical and moral implications to an atheist by talking about what Christianity says is acceptable, they're not going to buy it. I mean, you're not going to convince them. And one thing that we want to do is be able to reach conclusions that generalize, conclusions about medical ethics that appeal to different kinds of people across points of view, across ways of thinking. Now, why do we want to do that? Well, for one thing, it's in the interest of people in the medical field. They need tools, they need standards by which to make difficult moral decisions. The other is that this stuff ends up in courts periodically. I mean, we need a standard that applies for legal reasons across points of view, and especially across religious faiths. So that's one reason, is that the reality of religious diversity makes it problematic to appeal to any one religious faith in resolving issues in medical ethics. And the other issue is that ethical questions in medicine at this point are well beyond the scope of any religion's point of view. It's going to be hard to find anything in the Quran or the Bible that tells you what you ought to do in a case of genetic testing associated with in vitro fertilization. Or I don't think the word stem cell research is in the Quran, for example. I don't think that there's much in the Bible about how we ought to distribute scarce medical resources like kidneys. It's just sort of, I mean, there are general rules that you can sort of interpret into principles, but it's actually very difficult to do that. So in addition to the problem of religious diversity, we have the fact that most religious faith traditions just don't talk specifically about the kinds of ethical questions that we are dealing with at present in medical ethics. So there's nothing wrong. We're going to talk about religion at some point and its role in medical ethics a little bit later, because there are religious considerations. People tend to make decisions about their own care based upon their religious faith, and so we have to talk about how to deal with those types of situations. But what we don't want to do is make any particular faith the standard for decision making in medicine. So I want to encourage you, even if you are a person of faith, that's fine. That's great. A lot of people are. Most people are, in fact. I want to encourage you to go beyond simply what your faith says about issues and think critically. Think about things in this broad, general way that we're asking you to do. Think about how you can assess these difficult situations and questions in a way that would appeal across faiths. Because if you're doing that, you're really making some progress in medical ethics. Okay, what's the bottom line here? When we do medical ethics, what we're really interested in is providing reasons for thinking that some ethical conclusion is true. It's one thing to say, I think abortion is morally wrong, or I think abortion is morally okay. It's another thing to be able to give reasons for why we should think that that's actually true. So one thing we're interested in is what those reasons are. We'll give reasons that support your view. We're also interested in the basis of those reasons. So where do those reasons come from? Is it in virtue of some theory that you think is right? Is it in virtue of the relevance of some principle? Is there an argument that you could provide that you find convincing? What is the basis of those reasons in general? That's another thing that we're interested in. And so your job as a student of medical ethics is to be really thorough in identifying all the reasons for and against some ethical conclusions. So if you really want to be thorough about the question of whether abortion is right or wrong, you should think about all the reasons in favor of and also against both of those points of view. What are the considerations that make us think that abortion is morally acceptable? What are the considerations that make us think that it's not morally acceptable? And then think critically about those reasons. Are these good reasons? Are these reasons that generalize and cross-apply to similar kinds of cases? Or are they just sort of ad hoc reasons that we've plucked out of thin air that don't seem like good reasons in any other context? So once you do that, once you are thorough in identifying relevant reasons and you take a critical stance to those reasons, and you do that in a way that's sufficiently general that it doesn't rely on the truth of any particular point of view, whether that's religious or cultural, uh, you're doing now you're doing some real ethical work.